this so we have it to share later. Okay, so topic today, as I said, was nicotine replacement therapy. If I can just ask you all to mute your lines, that would be great. And we'll make a start. So just disclosures here. Now, just back to some basics for a minute. So nicotine replacement therapy, it's been around for an awfully long time. It's the most widely used medicine for helping people stop smoking. And as you all know, it works primarily by alleviating symptoms of tobacco withdrawal, making quitting easier, but it's certainly no magic cure. There are no true contraindications for NRT. Pretty much anyone can use it. As you know, it is able to be used in young people, so from 12 and above. And thanks for those questions already, Casino. I'll answer those at the end. Okay, so these data are from the Cochrane Review, and here you're looking at absolute quit rates in each of the products. Now, as you can see here, the best one overall is the nicotine nasal spray, and part of that might be due to its really rapid speed of action. Now, we don't have nasal spray here in New Zealand anymore. In fact, it's only available in a few countries. Now, it was removed from the market, I think mainly because it wasn't particularly well used. But overall, here you can see in the dark blue bars, the active treatment, the light blue bars are the placebo, so that's the comparator. And you can see overall, there's a rough, almost a doubling or a 60% increase in long-term quit rates. So NRT does work, but it's no magic cure. And one of the biggest problems with NRT is actually adherence to treatment and getting people to use enough of it for long enough. And some of the barriers that we always need to address, and I certainly, whenever I'm talking to my clients, I discuss the concerns they might have about nicotine. So reassuring them that nicotine doesn't cause cancer. Nicotine's not the element of tobacco smoke that causes the harm. That's everything else. And there's still this underlying fear of nicotine, perhaps partly because we've had very good public health campaigns warning people of the dangers of smoke, of cigarettes. But of course, people often think, well, there's nicotine in tobacco, so therefore it must be nicotine that causes the harm. So make sure you reassure people they're not going to overdose themselves on NRT either. People always tend to use less, not more. So spend some time in saying, what I say to people is you're in control. You use as much of this as you need to stay away from the smokes. That's kind of the key thing. You also know you need to address the taste of the oral products. And typically I start off all my conversations with, you'll hate the gum or the lozenge to start with, you won't like the taste. And in a hope, of course, that they use it and they realize actually it's not as bad as they thought it was, or at least as bad as I had made it out to be. So make sure you cover these things. Now, just a study here looking at the outcomes associated with using more NRT. This was a study of nicotine lozenges. And the bottom line here is that for each additional active lozenge used, it increased the odds of quitting by 10%. So that is associated with better outcomes. So, and this is a really hard thing to do. Most people underuse. You hold up a strip of lozenges or gum and you say, this is your day's supply. And people look at you and go, what, really? That seems a lot. They tend to forget a little bit about how much nicotine they're getting from smoking. And then they'll also, and Casino, this might go to your question, people are trying to work out the equivalence. I'm currently smoking 10 cigarettes a day. How much nicotine do I get from those versus what am I going to get from my gum or lozenge? Now, typically from a 4 milligram piece of gum, if you use it correctly, you'd get around about 1.2 milligrams of nicotine. And for a 2 milligram gum, it's about 0.8 milligrams of nicotine. So certainly less than half. How much nicotine people get from their smokes is a little bit more difficult. Usually it's somewhere between 1 and 2 milligrams of nicotine per cigarette. But people that have cut down can take much more nicotine out of those fewer cigarettes. So there's not really a standard amount of nicotine necessarily in a cigarette, and how much nicotine people get all depends upon how they smoke their cigarettes. When it comes to choosing an NRT product, the common practice is you just let people decide based on their general preference. There have been some studies that let people sample NRT first to let them try which one they want to use. NRT sampling may lead to better choice, and it might also lead to better treatment compliance, but actually it has no relation to the outcomes, i.e. helping people stop smoking. So at the end of the day, it doesn't seem to matter whether you say, here, I recommend that you use these products, versus letting people try them. You don't really get any difference in smoking cessation outcomes. And I think you can be guided by patients' preferences. Often people choosing between lozenge and gum comes down to, I don't like chewing anything, and therefore you'd use a lozenge. Or if they quite like gum, then don't be afraid to say, well, look, why don't we try patch and gum to start with and see how we get on. Now, this is important, and something that you should stress in all your consultations. Even if you slip, don't stop using your NRT. You all know those clients that they slip, they take the patch off, or they think they might want to smoke and they take the patch off first. Okay, so this is really important with patches as well. And this particular study showed, and it was a relatively high dose patch here, but people who left the patch on had a 5-fold reduction in the risk of full relapse. Okay, slips happen, but if people just keep using the NRT, they're somewhat protected against relapsing completely. So simple bit of advice, no matter what happens, even if you slip, just keep using your NRT. And here are some other data here about NRT use post-lapse. And by lapse, I just mean, a slip. Okay, they might have had a cigarette, they might have smoked a whole packet of cigarettes at a party. But these are data are getting a little bit old now, 2012, but this was a survey of stop smoking programs and also smokers who'd made a recent quit attempt. And of the stop smoking providers, 67% didn't even discuss NRT use post-lapse. So that's, the majorities didn't even mention it, and yet it's probably one of the more important things that we can do. So make sure, when you're talking about NRT with people, and the same goes with other stop smoking medicines, to be honest, get them to carry on using it even if they slip. A slip is not the end of the world. Slips happen. What you're trying to do is prevent them from going back to daily smoking. Okay, and when you look at smokers, you can see here that almost half overall stopped using NRT in the first few days after a lapse. So that's most people think, I've blown it, I'll stop using everything now. But those that continued to use NRT, most reported that it was helpful. So again, you can reassure people, don't worry, it's not dangerous. In fact, might even help you get back on the wagon. Okay, I just want to talk a little bit about faster acting nicotine replacement therapy. Now, you've probably all seen these data. This is the pharmacokinetic profile. So it looks at blood nicotine levels over time. So you can see there that this line, this fast, rapid peak, that's nicotine delivery from a single cigarette. Okay, so it's fast and it's high. This line here is your 4 milligram gum. 4 milligram gum's pretty good actually if people use it correctly. You can get good blood nicotine levels, and this is really good. This is correct use, right? Not just sticking it in your mouth and chew, chew, chew. But you can get good levels, but they don't get that peak, so around about half an hour after you're using it. Okay, so it's slower, but you do get a good peak of nicotine. Here's your nicotine nasal spray. So mouth spray would be similar. You get a faster increase, but not as high, and certainly nothing like smoking. And then here at this bottom line is your patch. And if you look at this insert here, this is the difference between the 24-hour patch, which we use, and the 16-hour patch. Okay, so your 24-hour patch doesn't reach peak levels until around about 6 hours after you start using it, but it also keeps your nicotine levels high at in the morning, right? So people stick it on in the morning, it rises slowly, stays up over the day, and then when you wake up the next day, assuming you've left it on overnight, you're not starting from ground zero again. Okay, so you're starting up here, which is beneficial, especially if people really struggle with that morning cigarette. So make sure if you're using the 24-hour patch, your advice should be, these are designed to stay on overnight. I want you to wear them overnight. Don't give people the advice straight away, oh, it might give you nightmares, and if you cause sleep disturbance, take it off. You want people to give it a good go to start with. Okay, because if people are very quick to stop wearing it overnight at just the smallest hint of sleep disturbance. But sleep disturbance is part of the tobacco withdrawal syndrome as well, and I'll cover sleep later on. Now, our fastest acting NRT that we have available is the nicotine mouth spray. Unfortunately, this isn't subsidized, so I know this can be a barrier for some people. Some services do have this available, but most don't. Now, the dose that we use is this 1 milligram dose here in the lime green. So you can see here, it works quickly. Okay, remember with the gum, you're getting your peak here. Here's 4 milligram gum in the purple line. Higher than the single shot of mouth spray, but slower. And remember, it's not always about just getting more nicotine. Sometimes it's about how quickly it relieves your urge to smoke. Okay, so this is typically why we use combination therapy. The patch gives you the nicotine slowly, but the gum or lozenge work a little bit faster. In terms of craving, the mouth spray can reduce craving within a minute of use. And you can see here in this study, even though it doesn't deliver nicotine that quickly, it seems to have this effect on craving much faster. Okay, so here's your 4 milligram lozenge. This was your comparator here. But you can see here in the green line, the mouth spray reduced craving significantly faster. And that's sometimes beneficial for people, especially if people don't cope with cravings very well. In terms of side effects, don't forget to talk about hiccups. Hiccups here. This is placebo in the green bar. Nicotine mouth spray side effects in the blue bar, and you can see there's a big difference in hiccups, and this is the effect of swallowed nicotine. Throat irritation a little bit, and then you have all these other symptoms that people complain about, but there's really not a huge amount of difference between the treatment products. Look at this for headache, for example. Those with the placebo reported more headaches than those with the active treatment. Okay, now I want to talk now about nicotine pre-treatment. Now this is about using NRT prior to the quit date. And I don't just mean a few days prior to the quit date, I'm talking about 2 to 4 weeks prior to the quit date. Okay, now I'll show you some data in a minute. There's just been a very large study finished in the UK, which should be published soon, that suggested still some benefit of NRT pre-treatment. Now, how might this all work? Well, it might simply be that people get practice in using the products before they quit. So they get good at using the gum, they know how to use the patch. Using the patch or even other nicotine replacement therapies might reduce the enjoyment of smoking. So if you're telling people, smoke your heart out, but wear this patch at the same time, then they might actually start to reduce the enjoyment of smoking, because their nicotine patch is providing some of the nicotine, occupying their nicotinic acetylcholine receptors, and so the enjoyment of the nicotine from their cigarettes is likely to be less. Now, this might be helpful, especially for people that are a little bit worried about quitting abruptly. Okay, but you need to use NRT regularly whilst you're still smoking. Okay, not just a piece of gum every now and then. Now, in terms of the evidence, at the moment, the studies suggest a small benefit here. So these are long-term quit rates by those that had pre-cessation or pre-quit patches versus those that didn't. And you see, there's not a heck of a lot in it, but that difference is significant. So a 5% increase in long-term quit rates. But again, for those that are a little bit worried about quitting abruptly, you could say to them, right, I want you to start your patches, I want you to start them 4 weeks prior to your quit date. Then on your quit date, we're going to add in some gum or lozenges and see how that works with people. It might also be important to increase the nicotine dose, and the easiest way to do this is use a combination of patch and fast-acting NRT. Now, most of you will do this anyway. So this is just, again, showing you that a combination is significantly more effective than single product NRT use. Okay, so most people you'll see, I'm guessing, are probably going to be using a combination of patch and gum or patch and lozenge, or even patch and inhalator or patch and mouth spray, if they can afford those. How this might all work, it may be that you just get more nicotine, or it may be that you have actually better control of your urges to smoke, because the patch really provides this background craving relief, and your intermittent dosing product, like your gum or your lozenge, is better for controlling that breakthrough craving. You can use more or less of it depending on how you're feeling or the situations that you might get involved in. And when I'm marking the NTS assignments, I often see some very strange dosing regimens. I just want to remind you about this ministry guidance for NRT prescribing. It's not perfect, but at least it gives you some structure for what you should be doing. So if you've got someone who smokes within an hour of waking and they smoke 10 or more cigarettes per day, then they get high dose patch with high dose gum or lozenge. Okay. If they smoke after an hour of waking and they smoke less than 10 a day, and just when you're asking people about number of cigarettes smoked per day, just check that they haven't recently cut down. I often say to people, have you always smoked 6 cigarettes a day? And sometimes they say, oh, no, I used to smoke 20. So base your, if they've just recently cut down, base your nicotine dose on what they were previously smoking. So these are on the ministry website. Don't forget to use those. Now, what about just increasing the dose of these single products? Well, we know you have gum that comes in 2 strengths. We know lozenges come in 2 strengths. And what you can see here is typically your higher dose product is more effective than the lower dose one. Here with patches, we don't have high dose patches. I'm not talking about the 14 and 7 milligram. These studies looked typically at 21 milligram versus 42 milligram patches, or something along those lines, or perhaps a 35 milligram patch. Higher patch dose, yes, there is some evidence that they're more effective, but it's a fairly narrow margin. Now, I think here it's because we possibly didn't tailor the doses. Either people got high dose or low dose, but not everyone needs high dose patches. Okay. Here's another study looking at 15 versus 25 milligram patches. These are the 16-hour patches, by the way, which we don't use. But when I started in this field, we only had 15 milligram 16-hour patches. Then they actually went up to the 25 milligram patch as the standard dose. And you can see there that the higher dose patch had better outcomes. Are higher dose patches more effective? It's a little bit confusing at the moment, and the studies haven't been particularly good. You can see here in this study where they used 0 placebo patch, 21, 35, and a 44 milligram patch. Overall, the 44 milligram patch did better, but not significantly better than the other active treatments. Now, I just wanted to carry on with this high dose patch issue because I know a lot of you double patch, and so this is where I'm kind of going with some of these data. So studies of high dose patch have produced modest outcomes in terms of quit rates, but it seems that higher dose patches are better at preventing urge to smoke, especially with this sort of cue-induced craving. Okay, so higher dose patches actually may be better for helping people that are particularly sensitive to cues. You know, that smoke in the morning when you're off with your tea break, or smoking when you're out with friends. Now, with high dose NRT, it might be the ability to titrate that might be more important, i.e. that you start low and go higher. And this is what we do with methadone dosing, right? No, you don't sort of go in there with a high dose. You start low and you increase slowly. You're looking for the dose that really takes away the drug cravings with methadone. And I think this is the similar approach with nicotine replacement therapy. So you can't look at someone and say, yep, you're definitely a 2-patch person or a 3-patch person. You just don't know. And so the best way to start would be on combination therapy, but also give people permission to increase their patch dose if they feel they need to. Okay, so you might need to titrate over time. Now, some stop smoking services actually aim for 100% nicotine replacement using the client's blood cotinine level. So when they're still smoking, they measure cotinine, which is the primary metabolite of nicotine. And then they aim for nicotine replacement that matches that. So in the Mayo Clinic, for example, their maximum patch dose is 84 milligrams per day. So that's 4 full-strength patches. And that would have been titrated or adjusted to the smoker's blood nicotine level. Okay. Now, there has been a trial that's done exactly this, that they've tried to adjust the nicotine dose based on the smoker's sort of smoking level of nicotine. This is a relatively small trial, but they took 310 smokers with a range of medical comorbidities. The standard care group just received standard dose patches with monthly dose decreases afterwards. And the other group, they aimed for 100% nicotine substitution. Okay, and they based this on salivary cotinine concentrations. Okay, now the way they did this is that the NRT doses were adjusted with the previous week's saliva cotinine concentration. So it was a little bit slow or past the point. But you can see here in these two arms, here's your dose adjustment arm. They started here around 30 and they went up, okay, to around the mean of 40, and your standard care group went down. So did it make any difference to stop smoking outcomes? Well, here's your 12-week quit rates. And you can see, although the dose-adjusted group had higher quit rates, it wasn't statistically significant compared to usual care. But it may be that just they weren't adjusting the dose fast enough. They were relying on the previous week's cotinine level to adjust the dose. And as you all know, it's really the first week that's really important. So we might need to work a little bit faster. Now, I just want to touch on a concept here. And this was a study that looked at cigarette consumption based on nicotine patch dose. Now, these were people not stopping smoking, but essentially they were told to keep on smoking as they increased the patch dose. And as you can see, once they got to 3 full-strength patches, they smoked less. Okay, so this is the amount of nicotine they're getting from their cigarettes. And as you can see, at baseline, they were getting about 36 milligrams. By the time they got to 3 full-strength patches, they were smoking their cigarettes less. Okay, so it's going in the right direction, but not at 100% reduction. So what if we sort of carried on this curve, could you get 100% suppression of smoking? So here you'd have to say to people, right, I want you to start using your patches prior to quitting, and I just want you to keep increasing your patch dose until you just can't smoke anymore. Okay, so the theory, and this is theory, this is not in practice at the moment, maybe we could get to the point where people just didn't feel like smoking, or perhaps we gave them too much nicotine and they felt sick. This is something that we have recently tried. And I'll just show you some data soon. We've just finished this study. But the idea here is you start NRT whilst you're still smoking. You slowly increase the patch dose until people don't feel like smoking anymore or feel sick. Okay, and this way people would find the dose that satisfies their level of dependence. Okay, and this time the dose increase is really just based on their enjoyment of smoking or not enjoying smoking, as the case may be. So this was our recent pilot. I did this with some colleagues in Argentina, and we took 50 smokers and we started patch use 4 weeks prior to quitting. And they were instructed to increase their patch dose each week. So they started on 21 milligrams, keep on smoking. Next week, as long as they weren't feeling sick, they went up to 2 patches, then to 3 patches, then to 4 patches. Okay, and that then coincided with their patch dose, and then they carried on that for a while, then they decreased their patch over time. Now, interestingly, 90% of all people, 90% of those 50 smokers progressed easily to 3 full-strength patches whilst they were still smoking. So we didn't overdose people even when they were still smoking here. Those that progressed to 4 patches, so there were 36 that got to 4, these people, as you may not be surprised to hear, smoked more cigarettes per day and had a higher carbon monoxide at baseline. So they were your more dependent smokers. So the more addicted you are, the more nicotine you're used to getting from your cigarettes, and the more that you can tolerate this patch dose increase. Now, this was just a pilot, but the 4-week quit rates in the study, same measure we use in our stop smoking service, was 82%. That's pretty high, higher than we see in most times. Now, there may be other reasons for that, but this is perhaps something that we might look at using in the future. It does need to be tested properly, but it combines both this pre-treatment but also a more tailored dose of patching people up. Okay, just something on special groups. Nicotine replacement therapy in pregnant women can be used. Remember, we're meant to talk about risk versus benefits here. Nicotine replacement therapy is not 100% risk-free in pregnancy. There's very little that's 100% risk-free, but it's much safer than smoking. What you're looking at in these things are called forest plots. And what they do is they combine the data from all of these studies, both placebo-controlled and the non-placebo-controlled here. They take all the data and they combine it into one result. And these little diamonds here at the bottom show you the overall effectiveness. Now, if these diamonds or the tails of these forest plots cross this line here at 1, it's saying that there's no evidence of effectiveness of NRT versus placebo. But what you can see here overall is there is a significant effect of nicotine replacement therapy in pregnant women who smoke. It's modest. There's a 41% increase in long-term quit rates. Quit rates later in pregnancy here, but it does work. Use in young people, I'm afraid, not such a happy story. So very few studies here, and you can see this diamond's right on one. So no evidence of effectiveness of nicotine replacement therapy in young people. That may be partly due to just a couple of studies, or a handful of studies with small numbers of participants. But just as a matter of interest, this was published late last year. There is evidence for group counselling. So it seems that group counselling works well for young people, not individual counselling. So someone asked me a question about this recently. What would we do for young people? It seems perhaps that if you're going to work with young people, try group counselling or group-based treatment. But having done group-based treatment with young people, you got to make it fun. And by fun, I think probably competitions, probably incentives here as well to try and really get them coming back and engaging. There's no harm in using NRT, but remember, young people are early in their smoking careers, so to speak. They may not all be highly dependent smokers, and a little bit of social support actually may be all they need. People in treatment for or recovery from substance use disorders, so alcohol recovery, for example. Is NRT effective in this group? Good news here, it is. It roughly doubles the chances of quitting smoking long term. So if you're seeing people recovering from other drug and alcohol dependencies, you can certainly recommend NRT use. And what about preoperative NRT use? As you know, quitting smoking prior to surgery is one of the best things people can do to improve their chances of recovery. This was a systematic review published a couple of years ago now, and their review concluded that there was no evidence from any human studies that NRT increases the risk of healing-related or cardiovascular complications. Okay, so no evidence that NRT makes things worse. On the other hand, there is really good evidence that stopping smoking prior to surgery makes things lots better. And so their conclusion here was that policies that prohibit the use of NRT in surgical patients should be re-examined. So those of you working in hospital settings, this might be a discussion to have with some of your surgical colleagues about re-examining policies that prohibit NRT or any nicotine use except from smoking. Now, I just wanted to touch on sleep disturbance. Now, as I already alluded to earlier, there's some evidence to suggest that 24-hour patches may have better morning craving relief. And this study showed that. So these are craving scores here, and here's craving at the beginning of patch use, and here's craving at the end of patch use. This one's 16 hours, this one's 24, and you can see the 24-hour patch did have a reduction. This wasn't significant here on this one. This is just a visual analog scale, so people said, you know, this would be terrible craving at 100, and 1 would be no craving whatsoever. And you can see there was a significant benefit of using the 24-hour patch. But some of the things people worry about in terms of 24-hour patch use is nightmares or sleep disturbance or somewhere along those lines. And I often hear people telling people, don't wear your patch overnight, you might get sleep disturbance or nightmares. Well, in this particular, I just wanted to present some data here, published quite a number of years ago now, but this was looking at sleep disturbance in 2 different patches. One, the 16-hour patch, so that's taken off before they go to bed, and the 24-hour patch, which is left on overnight. Now, what you're seeing here in these different colored lines, the yellow line is a sort of a questionnaire that looks at refreshed sleep. So actually, there's some evidence to suggest here that those using the 24-hour patch had more refreshed sleep than those using the 16-hour patch. The thing I want to point out here, though, is these micro-arousals. So these are the small awakenings during the night. And you can imagine if you have more of these micro-arousals, then you might be more likely to feel tired the next morning. Well, actually, what you see here is that there was a decrease in micro-arousals in those that got the 24-hour patch versus those that got the 16-hour patch. And so the authors of this particular study concluded that the 24-hour patch is more suited to counteract the deleterious sleep effects of tobacco withdrawal. So what you might be seeing here with people that don't sleep well or they wake up during the night may simply be an effect of tobacco withdrawal. If that's the case, then wearing the patch overnight is a much better way to counteract those. So my message to you here is don't be too quick to tell people to take the patch off overnight. Give them a week. See how they go. If they come back and they're moaning and it's just been horrible sleep, get them to discuss this with them. Say, well, look, it might be due to tobacco withdrawal. It could be due to the patch. Do you want to try taking the patch off at night to see how it goes? But just check with them. They might be okay with the sleep disturbance. It may not be that bad. So don't be too quick to sort of warn people to stop patch use overnight. Okay, just again to reassure you about serious adverse effects of NRT use. This was a systematic review published last year that just looked at potential health risks. Really, there's absolutely no association with cancer, cardiovascular disease, stroke, or other serious health events. The only thing that the suggestion of some sort of relationship with NRT is respiratory congenital abnormalities. So this may be that nicotine has some adverse effect on lung development in the infant. So this is why we can't say that NRT is 100% safe in pregnancy. It's not. But of course, if the woman was still smoking, there'd be this plus many more. Okay, but otherwise, in these other health risk areas, there's no association with NRT use and increased risk of cancer, for example. So just to conclude, what can you do now? Make sure people are using the right NRT dose. Make sure you use those ministry guidelines. Make sure you try and utilize faster acting products, getting people to use enough of them. Be a little bit smarter with how people use them too. If you've got someone that smokes mainly when they're out socializing, make sure they're all ready to go with their patches and gum prior to getting out to the party that they might be going to. Make sure you use combination therapy. Encourage the use of a sufficient dose. Now, by sufficient dose, that's very individual to the client. My advice here would be to start low, so start on your standard combination therapy, but if people need to use more, encourage them to use more. They're in the driver's seat. As long as you're monitoring them over time, they're not going to fall into any problems. And the worst that's going to happen is people would feel a bit sick if they had too much nicotine, and you can always pare that back if that happens. So don't be afraid to tailor your dose a little bit. The primary goal for what we're trying to do is help people stop smoking completely. And for some people are going to need to use higher dose NRT, and as you know, for a little bit longer. And again, make sure that you encourage people to carry on using NRT even if they have a slip. I think the future, we're going to do things a little bit differently. NRT preloading or pre-treatment, as I've mentioned before, shows some promise. Tailoring NRT choice and dose is probably worth some further exploration. We may have some genetic testing in the future to help us inform choice of products. People that metabolize nicotine quickly, for example, may be better on one of the non-nicotine products or even higher doses of nicotine. And I think development of NRT delivery systems that provide better sensory replacement may improve the efficacy of NRT as well. Perhaps that won't progress as fast as we would like, given now that we've got electronic cigarettes, which of course give you both nicotine delivery once you know how to use them, but also some good sensory replacement, which many people like. Okay, so I'll end there, and I'll just stop sharing my screen. And I'll unmute you all and happy to take any questions.